Welcome and thank you for joining us. My name is Conchita Landefont, and I'm the Training and Engagement Officer for Glaucoma UK. And I would like to introduce Professor Anthony Khawaja. He's Honorary Consultant Ophthalmic Surgeon and Professor of Ophthalmology at Moorfields Eye Hospital and the UCL Institute of Ophthalmology. For this session, we're going to focus on the new eye drops, side effects, and the impact of other medication. Now, I'm just going to launch a quick poll. And then once I've done that, I can. Right, Helen.
Yes, Conchita.
I can't see my controls. Right.
You'll have to unshare your presentation.
Right. I'm going to stop sharing. There we go. Right. Sorry about that. So
the controls actually went to the top. Conchita should have said to you. Yeah. So go to the more.
Right, there we go. Sorry about this. Right, I'm just going to launch the poll about where we're starting from, and then I'll be able to share again. Right, there we go.
Perfect, Conchita.
Right. So we're getting lots of nice responses coming in. So once I've waited a little bit longer for the polls, I shall actually hand you over to Anthony because obviously he's a star of the show, and we want to make sure that we get most of the time with all the questions. So we just bear with me a little bit more. We're kind of getting to be almost kind of a few more questions. I'm just going to wait another couple of minutes. So I've actually got 50 responses. So we've got 60 people online already now, which is really good. And I've got over 50 responses, but that's brilliant. So, and actually, as I'm speaking, the numbers are kind of like building up. So obviously more and more people are joining in, but because the poll started, obviously they won't be able to continue. So I'm just going to carry on for a little bit longer, and then I'm going to end the poll and hand over to Anthony. So I'm going to do 20 more seconds. So make sure you get your polls in. Perfect. Right, I'm going to end the poll now and hand you over. So I'm just going to end the poll and hand you over to Anthony.
Thanks very much, Conchita and Helen. Do we know the results of the poll, or we'll find that out at the end, do we?
We'll find that out at the end. We can basically, the polls are what people know and then how much obviously we've managed to tell them. So we can share that at the end, but thank you.
And just let me know if you can see my slides. Okay.
I can see it looks perfect.
Okay, great. So welcome everyone, and thanks for joining. As Conchita said, I'm a glaucoma specialist at Moorfields Eye Hospital. I'm also a Professor of Ophthalmology doing research into this aspect of glaucoma and other aspects at UCL. One thing I think it's worth saying, at the beginning of all academic presentations, we have to give our financial disclosures, and I do give. I am a consultant to some of the companies that make these medications, so they consult with me for advice. So this is what Conchita asked me to speak about. One was the first new eye drop we've had in glaucoma in this country for over 20 years. That's Roclanda. To go over side effects of all eye drops, and also talk about some of the other medications we take for conditions that aren't glaucoma, and how that might influence our glaucoma and risk of glaucoma and so on. So the simple place to start, and you all know this already, the only proven way we can treat glaucoma to help prevent it getting worse is to lower the pressure inside the eye. That's called the intraocular pressure. And all treatments, not just medications, laser and surgery, they all aim to do that, to lower the eye pressure. And as I'm sure you know, the fluid inside the eye is made behind the coloured bit in the eye, the iris, blue in this patient, and it flows through the pupil into the front part of the eye. Now, some of that flows through what you can see there, the trabecular meshwork and the Schlemm's canal, but there are actually other ways that fluid can leave the eye. But it's the balance between the amount of fluid that's being made and the fluid that's leaving the eye that generates the pressure inside the eye. And this diagram in the corner here is like a schematic of that. So fluid, let me see if I can bring up a laser pointer. So fluid is made behind the iris, blue in some people, brown in others, and it flows through here and then comes out to the front. Now, the bit that was mainly highlighted in that video is where most of the fluid flows out of. That's like over 80%, and that's called conventional outflow. The conventional plumbing goes through what's called the trabecular meshwork, that sieve-like device. But fluid can also flow through another part, which is called uveoscleral, or is called unconventional outflow. And that's essentially how fluid leaves the eye. So you've got something making fluid, the tap, if you like, and then the way fluid can escape, the plumbing, the drains. And normally that's well matched, and so the pressure in the eye doesn't go high. But if you have glaucoma, you have a tendency for that pressure to increase, and that's normally due to a problem with the plumbing side, something to do with this outflow. Now, up until last year, these were the medications that we used to treat glaucoma. The most common ones, and we'll go into the sort of specific types, are prostaglandin analogues, and they work by increasing this outflow, the unconventional outflow, the uveoscleral outflow. Then the majority of the other commonly used medications, the main ways they work, the beta blockers, the carbonic anhydrase inhibitors, and the alpha agonists, the main way they work is actually by making the eye produce less fluid, less aqueous humor. And then some of the older medications that are still occasionally used, the parasympathomimetic agents, that's essentially pilocarpine. We're not quite sure how it works. Some people think it might be by increasing flow through the trabecular meshwork, so through the main way that fluid usually leaves the eye, the trabecular outflow. And so this was like, these were all the medications we were using for like the past 25 years or so, until this new one's become available. That's the brand name is called Reclanda, and it's actually a combination drop. That means it contains more than one medication. It contains latanoprost, which is a prostaglandin analog, and that's the most commonly used glaucoma medication in this country, with a new drug that's not previously been available called nitacidil, and that's what's called a Rho kinase inhibitor or a ROCK inhibitor. Now, this in this country is not available on its own. So the only way that we can have access to this new medication is in a drop that's combined with latanoprost. And I think the idea being is that most people would be on a prostaglandin analog anyway. So if you're adding in something new, then you might as well put it in combination to make it more convenient. And nitacidil you only need to give once a day. Latanoprost you only need to give once a day. So combining these two seemed like a good idea. Now, nitacidil and nitacidil combined with latanoprost has been available for a long time in the United States, for over 5 years now. So it's not like it's brand new to all glaucoma specialists. So my colleagues in the United States have got at least 5 years experience with this medication. It was approved to be used across the European Union and the UK a while back, and the actual launch in the UK, where it was you could actually buy it in the UK, was in June of last year, so over a year ago now. And we'll talk more about the availability of it later, because some of you may already be using the medication or have access to it. And some of you, unfortunately, might not, and we can talk about it later. Now, how does Reclanda work? Well, it is really the only drug that we know very much specifically works on this conventional outflow. So this plumbing here going through the trabecular meshwork and out of the eye that way is where 85% of our normal plumbing is, and that is where Reclanda works. Now, I could have gone into some detail about how it does that, but I don't think that is really of the main interest. That's all you need to know, is that it's working through this way, and to understand that that is actually not where most of the other drugs that we have available now work. Most of them increase the unconventional outflow, which is kind of sneaking in through here, the uveoscleral outflow, or by producing less, making the eye produce less fluid, less aqueous humor. So this drug is working in a different way, and that may have some potential advantages. So what are the potential advantages of this new medication, particularly the notacetyl component, which hasn't been available before? Well, one thing is that it's once daily. A lot of our other drops you have to use twice or three times daily, whereas this, you get the full effect using it just once daily, which is convenient. And as I was just alluding to, this drug works in a different way to the other drugs. So if you're on a prostaglandin analog and then a beta blocker, you're on a drug that increases the uveoscleral outflow, but also increases the amount of fluid the eye produces. And then if you keep on adding in other medications which reduce the amount of fluid the eye produces, you're kind of almost repeating yourself potentially. So to have a new drug which works in a different way could have advantages. And while I'd say it's far from proven, there are some studies which suggest Reclanda is particularly good at getting a reduction in the eye pressure, even when your patients are already on a number of medications, because it works in a different way. The other thing that research is maybe starting to show, so that is that even if the eye pressure is at a low level already, you can still get a further reduction. So normally, for many drops, they work best if the starting pressure is high. So let's say the starting pressure is higher than 21, you're more likely to get a good reduction in the eye pressure. But if the starting pressure is something like 15 and you need to get it even lower, it's quite hard for medications to do that. But it seems like Reclanda is good or better than some of our other drops at doing that. I won't go into the details, but it's probably because it's what's called reducing the floor effect, in that other modes of action, you're never going to get the pressure lower than a certain amount because of the resistance in that conventional outflow, the trabecular meshwork, but also the bits beyond that, the Schlemm's canal collect channels and the veins at the end of it. Whereas because Reclanda works on that bit, it's possible to get the pressure even lower, potentially. And again, I think this is far from proven, but research studies seem to be pointing in this direction. So those are the advantages. What are the downsides of Reclanda? What are the side effects? Well, the real major side effect is a red eye, because this is quite common. And depending on which study you look at, maybe up to half of people report some degree of redness. In some of the more recent studies, looking not in trials, but in real world data, it might be nearer 30%. And the reason people get red eyes is actually how Reclanda works. Because Reclanda is relaxing some of the vessels which fluid leaves the eye through the plumbing, essentially. Because it's relaxing it, it also relaxes the blood vessels on the surface of the eye, so they become wider and sometimes leak a little bit of blood. And that's the cause of getting the red eye. So it's actually a sign that it's working. And yes, you can get small hemorrhages, that means small little bleeds. But because it's a reflection of how the drop's working, it's quickly reversible. So if you stop the drop, the redness goes very quickly, like within a day or two. And it's only there when you're using the drop. And I'll show some pictures of it later. The next most common thing is something, sounds strange, corneal verticillata. But I'll summarize that and say that the clear window in the front of the eye, which is normally completely transparent, can develop faint lines in it. Now, most of the time, that doesn't cause any problems. So as a patient, you wouldn't notice that. You can't see it, and it doesn't affect your vision. And to date, it's shown that it's reversible. It's not as quickly reversible as the redness, but over time, if you stop the drop, these lines do go away. It might have a bit more itchiness and discomfort than some of our eye drops, like the prostaglandin analogs, like latanoprost, but maybe as much or less than some of our other existing medication. And people can develop an allergy to it. So this is what the redness looks like. So this is very zoomed in onto the white of the eye, because that's the bit where we get redness. And these blood vessels that I'm showing you here end up becoming wider, and sometimes they leak a little bit of blood. These areas I'm showing you now are very tiny hemorrhages. Now, interestingly, this patient, and I've got another photo of this patient, you can really see the widening of the blood vessels there. And these blood vessels may well be some of the blood vessels that the fluid inside the eye are flowing through. That's how it's working. It's reducing that resistance, increasing the usual way fluid leaves the eye into the bloodstream. This patient actually didn't feel they had red eyes. They hadn't noticed it. It was only when I, on my equipment, zoomed in, I could take photos like this. So actually, I think who's using this medication, almost everybody will have these dilated, these opened up blood vessels, but not everybody would notice that their eyes have become red to that degree. So as a patient, what I tell my patients is, if the idea of a red eye really bothers you, we might need to think twice about using this medication. But the good news is that, half or less, it's only half or less than half that will develop some noticeable redness. And even if you do and you find that troublesome, it goes away immediately on stopping the medication. So depending on the patient and what other options you have, this would be one of the main factors to consider. If you're interested, these are the faint lines that can develop, the corneal verticillata, which usually don't affect the vision and are reversible, can go away. So what about the availability of Reclama? So I was quite excited when this was available for my patients. So as soon as it was in June last year, even though at my hospital, at Moorfields Eye Hospital, we didn't have it available, I was telling some patients who are heading towards surgery anyway and really didn't want glaucoma surgery, well, you could ask your GP to prescribe this medication for you. But I actually got into trouble because when GPs weren't familiar with it, they were contacting Moorfields Pharmacy. Moorfields Pharmacy was saying, well, we can't help you because we don't have it approved on our formulary yet. So they contacted me and said, can you stop telling patients to get it prescribed by their GP? But quite quickly, within a month or two, this was approved by Moorfields Eye Hospital, and we have it available on our pharmacy. And so then, that we've been able to support patients getting it from their GP or locally, or having to get it directly through us. But that's just locally. Some of my private patients, which come to see me from further afield than London, have really struggled. For example, I have a patient from Birmingham, a very big city, who cannot get Reclama locally and has to get private prescriptions from Moorfields. So that's not good, really, that there's a bit of a postcode lottery. For anyone involved in glaucoma care wants this medication available for all glaucoma patients. But the National Health Service has to know that it's good value to do this and it's the right thing to do. So the normal route for that is approval through an organization called NICE. And the good news is NICE have already done their consultation and got experts to advise them on this. I was one of their experts, and they should be publishing their guidance soon. And while I think that's not, the decision isn't public as yet, I think what we can say is we can be optimistic that really at the latter end of this year, I think Glaucoma for some patients, because there'll be guidance on who it should be prescribed for and who it shouldn't, that it should become more available. But watch this space, and I know Glaucoma UK, who are also involved in the consultation with NICE, will be updating their members with this information when it becomes available. Okay, so that's part one. That's the first new medication we've had in over 2 decades to help us manage our patients. Let's now go for the drops that have been available for a long time. So the most commonly used medication now in glaucoma are the prostaglandin analogs, and these are the drops latanoprost, travoprost, bimatoprost, tafloprost. Those are the generic names. There are branded versions you might have heard of: Zalatan, Travatan, Lumigan, Saflotan. But these are the generic names. And these drops are they're great because they're once a day, and they're generally well tolerated. There aren't that many side effects. The side effects you do get tend to be local, and that means you see it around the eye rather than anything affecting your general body health. The commonest ones are eyelash growth and the skin going a bit darker. And this is more likely to happen with some of them, like bimatoprost, rather than latanoprost, including this sort of loss of fat around the eyelid, so your eyes can look quite sunken. I don't know if you can still see an image of me. I've actually got quite sunken eyes, and that's just how I look. And it's not because I've been using prostaglandin analogs, but that's how your eyes can end up looking if you use them. There are some rarer things, like it can cause swelling of the retina at the back of the eye. And if you've had the herpes virus infect your eye, it can cause a recurrence of that infection. Most of these side effects are reversible. So if you stop using the medication, then it can come back. I'm not so sure that the loss of the fat around the eyes, whether that necessarily does come back. There should be caution in pregnancy. I'll talk a bit more about pregnancy later. Really, with any medication, there should be caution in pregnancy. But particularly, you can use prostaglandin analogs to incite labor. And so there might be a fear that using these drops earlier on in pregnancy might incite an abortion or an early delivery. Okay, the next most commonly used and next, I guess, strongest effect drops are the beta blockers. Many of you may be using tablet forms of beta blockers for your blood pressure or for angina or for to slow down your heart rate, because these medications, the most profound effect they have is by slowing your heart rate. There were different types that you used for the eye, but nowadays really the only available one is timolol, and it comes in various formulations and often in combination with other drops as well. And really, for timolol eye drops, there aren't very many local side effects, as in effects that are noticeable around the eye. It's very well tolerated like that. But the effects can be systemic, how it affects your body. And actually, strangely enough, just by taking it as an eye drop, it gets absorbed into your system and it can slow down your heart rate. Now, for a lot of people, slowing down your heart rate is actually a good thing. It makes you live longer. But for some people, it might slow them down. It might limit the amount of exercise they can do, so a reduced exercise tolerance. Now, if you've got asthma or a tendency towards airway diseases, it can make that worse as well. And so it can make asthma worse and make people wheezy, because actually one of the main treatments for asthma are not beta blockers, but they're beta agonists, things to increase the beta receptors rather than block them. So this, you wouldn't want to take a beta blocker if you're having to take a beta agonist for another disease. Now, some of these other side effects, like nightmares or impotence, problems with erectile function, really are normally for patients taking the tablet form rather than drop form, but could potentially be a side effect from beta blockers. So worth noting. And so we wouldn't prescribe this medication for people with asthma or airways diseases. I personally don't prescribe this if people are already taking a tablet version of the beta blocker, such as atenolol or propranolol. So I think if you're already taking the tablet version, you're having the effect. By taking the eye drops on top, you're probably not increasing the amount of pressure that's lowered inside your eye, but increasing the risk of side effects. Carbonic anhydrase inhibitors. These are often really third-line medications, sometimes second-line. The drops are brinzolamide, dorzolamide, but there is a tablet version called acetazolamide or Diamox. These drops sting. And the important thing to know is that the stinging isn't harmful. It's just a feature of the medication. The other thing, it can give you a metallic taste. It can cause an allergic reaction on the skin around it. That's one of the most common what's called a dermatitis. The tablet version has got other side effects. That's really beyond what we're planning to talk about in the webinar today. But that most commonly causes tingling around the mouth and in the fingers. It can make people feel tired. And if it's been taken long term, it can start to affect the salt balances in the blood, which could be harmful. So people on the tablet version long term need to have their bloods checked. It is, in a way, a type of sulfur medication. And for that reason, if you're allergic to sulfur drugs, you really should potentially avoid these drugs, particularly the tablet version. Another commonly used medication, just to say, these medications ideally should be taken 2 or really 3 times a day to get the maximum effect. And similarly with the alpha agonists, brimonidine and aproclonidine, these need to be taken 2-3 times a day. The main thing with these medications is that a proportion of people get an allergy. What's really important is that this allergy can come on even after a year or 2 years. So if you weren't allergic to this medication, it could still somehow just come on and the allergies start even down the line. And that confuses some people because they think, oh, well, it can't be an allergy to that because I've been on it for so long, but it can be. In some patients, it can make them feel tired, actually. And in some people, I've seen this rarely, if you suffer with heart disease like angina, it can make it worse, especially on the stronger strength of the aproclonidine drop, which is usually only given to patients undergoing laser eye procedures. You shouldn't really take these medications if you use what's called a monoamine oxidase inhibitor, which is often given for a treatment for depression. And you shouldn't give the brimonidine version to children because this drug actually crosses into the brain. And while the brain's developing, you don't want to do that. And that's really how it can cause tiredness in some patients. These less commonly used medications, so that is essentially pilocarpine, which funnily enough is now available in the United States, where I am now, to treat the loss of being able to see for near, what's called presbyopia, as we all get older. It's interesting it's being marketed as that. I'm only here on holiday, by the way. I am still practicing in the UK. These side effects, it can actually give a bit of a headache. Because the pupil's being made smaller, it can make the vision darker, and theoretically, it could increase the risk of retinal detachment. And you wouldn't give it to patients who have problems with urinary outflow or asthma. This is just one slide I put in to just say this. those are some of the more common side effects. We are all different. We all have our unique genetic makeup. And it might be in you have a side effect that's definitely caused by the medication. That's not well described or well known by other people, but it is the case in you. And so, as a glaucoma doctor myself, I'm very open to medications causing side effects that I haven't previously come across in other patients or have not been reported. And really, the way to know for sure is to trial stopping the medication, see if that side effect goes away, and then restarting it, see if it comes back. And if you do that, you go through that process and come back, then I think you can say that it is that medication causing it in you. I brought up pregnancy earlier. Look, no drug is entirely safe in pregnancy. And so if you are a younger patient with glaucoma or at risk of glaucoma and need to be on these medications, you need to talk about this with your doctor. And there are risks and benefits for each of the classes of medication. And it's a complex topic. And so I'm going to leave it at that. Ideally, you'd avoid medications altogether, and there are some straightforward, safe laser treatments that can help lower the pressure to tide things over till the baby's been delivered and mum's no longer breastfeeding. Now, the beta blocker, which I talked about, slowing the heart rate, one other thing that can contribute to and is sometimes overlooked is falls. And we even wrote to the Lancet, which is a general medical journal a while ago, but in 2006. But the message is just as important now. Let's say you have a fall, and you go to you're being seen by the cardiologist or by the A&E doctor, and they ask what medications you're on. It's important you tell them your eye drop medications as well. But if you say timolol, then they'll know, oh, they're on a beta blocker. That could slow down their heart rate. And that might mean they can't maintain their blood pressure well enough under certain circumstances and have a collapse, have a fall. But some of our combination drop names like Cosop, Combigan, Zalacom, Duotraf, Ganford, these don't have clues in them that they contain timolol. And so it's important that whoever's assessing you is aware of this. And I've seen the situation many times where somebody's even been close to having a pacemaker put in because their heart rate's been slow and they haven't appreciated that it's because they're using an eye drop medication. And just by changing the medication, we avoided the need to have a pacemaker. A very common thing that all people get, especially as they get older, is dry eyes. The fancy name for dry eyes is ocular surface disease, isn't it? Basically, your eyes are such delicate organs that have to carry out such a precise and sophisticated function, and it needs to have a smooth surface to focus light properly. And if that surface is irritated or not smooth, then it's ocular surface disease or dry eyes. And it's really common in patients with glaucoma. And that's because the medications, the eye drops that you're putting in the eye itself, irritate the surface of the eye. We know that the larger the number, the more medications you use, the more likely you are to have this ocular surface disorder, as you can see in this graph here. And it's not just the number of medications, also the number of separate drops that you have to use. So look, this is almost a fact of life. A lot of people not on medications can get dry eyes, ocular surface disease anyway. There are preservative-free versions of a lot of our medications. There isn't for Reclanda yet, but for most of the others, there are preservative-free versions. And if you do have ocular surface disease and you're using glaucoma drops, I think it's a very good idea to move to the preservative-free version, because sometimes it's not even just the medication, it's the preservatives in them to help keep the drop free from infection that can irritate the eye. And there are versions of drops which don't need the preservatives and can stay free of bacteria and bugs to use them safely. Right, now on to the final part of the talk, and that's what about the medications I take for blood pressure or for cholesterol or for any of these other things? Are any of these other medications influencing my risk of developing glaucoma or potentially the risk of the disease getting worse if I do have glaucoma? Well, there are some which are very well proven and known, and one of the main medications that can cause glaucoma if you didn't have it, particularly in those people who are susceptible, or might make your glaucoma worse if you've already got it, are steroids. Now, steroids reduce inflammation, so they're given for a lot of different types of diseases, and they come in different forms. And the type that can cause glaucoma, they cause glaucoma by affecting your conventional outflow. That trabecular meshwork, that sieve, it ends up kind of blocking it up while you're on the steroid. So fluid, which normally 85% of it leaves the eye through, that can't, and then the pressure goes up. Now, it's most likely to do that if you have a steroid implant injected inside the eye. It's next most likely if you're taking steroid eye drops for a period of time, and next most likely if you're taking steroid tablets or through the vein. It can occur at any time. So usually for the people who are really sensitive, so the first thing to say is not everybody is susceptible to this. About a third of people actually will get steroid, if they take steroids for long enough, close enough to the eye, will get glaucoma from it, will get high pressure from it. 2/3 won't. So if you are susceptible to it, it might become apparent. It won't become apparent until it's been at least 2 weeks. But then over time, whether the effect becomes more apparent, even up to a year here, there might be some people that don't develop this effect till a year of using steroids. So worth knowing. Now, what about other types of steroids? Like sometimes people need a steroid nasal spray if they've got problems with that, or steroid eardrops, or steroid creams. Well, these are less likely than the eye drops to cause high pressure. And I think it's not really well known how much of a contribution it has. My feeling with this has always been that if you need to take it, if it's for just a short period of time, that's fine. If it's for a longer period of time, longer than a couple of weeks, then you should just get the pressures checked. Now, if the pressures do go up, then you might need to have that conversation. Well, maybe I shouldn't take the steroids, or maybe I need to have more intensive glaucoma treatment to cover me for that. But if the pressure don't go up, then as long as they're monitored, then it could be safe to use some of these other things to help control the other problems that we have. Now, one thing I'd say about the creams, steroid cream, I had a patient who was applying a steroid cream to something on their foot, but they weren't washing their hands afterwards. And we know from the COVID pandemic how many times an hour we all touch our eyes, and we do. So the key is if you're using a cream, even if it's nowhere near your eye, make sure you wash your hands fully. Now, medications that can decrease glaucoma risk, these beta blockers I've told you, we know that beta blockers, like propranolol, this is since the 1960s, can lower the eye pressure and theoretically at least can lower the risk of glaucoma. Now, not in everybody. For some patients, some doctors believe that these beta blocker tablets might lower the blood pressure, which is bad for glaucoma. But that's one level of complexity beyond this talk, really. Most frequently, when you pull out the information and it tells you don't use in glaucoma, it's because of this risk of what's called angle closure glaucoma, or causing acute angle closure where the pressure shoots up. Now, I'd say there are a group of medications where this is definitely a risk. They're the anticholinergics, and they work by they increase risk by causing what's called a pupil block, where fluid builds up behind the iris and pushes it forward, closing the drainage angle completely, and the pressure can shoot up to 60, 70, very high. And these medications are dilating drops to open the pupil, which you get in the eye clinic. Some treatments for urinary incontinence, treatments to relax muscles, some asthma treatments, and some, not all, antidepressant treatments, particularly what's called the tricyclic antidepressants like amitriptyline. Now, there are other drugs that cause angle closure glaucoma, but they're not via the pupil. I won't go into the details because we're running out of time, but they work by another very rare effect. So most people who take these medications won't get angle closure. And it's probably just some people with a certain genetic makeup that do take this. So these drugs, it's not, well, I've got glaucoma, I shouldn't use these drugs. It's just if you're unlucky, if you've got a certain genetic makeup. So if you are thinking of going on this drug, I think it's probably likely to be fine, but do let your glaucoma specialist know. Now, there's lots of medications that have just been implicated to cause this acute angle closure. We recently wrote this review for a general medical journal called JAMA, and there's this whole list here. And lots of cold and flu medications even have these. And what I'd say is, maybe be a bit cautious, but these aren't, I would say, firm contraindications. If you have angle closure type of glaucoma, you're probably still fine to take cold and flu medications, but do discuss it with your glaucoma specialist. If you want more information about which specific ones to be careful with if you're at risk of angle closure glaucoma, we've recently written a leaflet on narrow angles, which is the thing that predisposes you to angle closure glaucoma, and that lists on this website here the medications that you should be careful with. Now, what about ones that are just implicated to affect the risk of primary open angle glaucoma? Well, this is a research area I'm interested in. And while we found some medications may be associated with an increased risk of glaucoma, with the vast majority of patients, I don't even mention them because it's far from proven. But if you're a patient of mine who unfortunately is continuing to lose vision despite best glaucoma treatment, I do mention some of these classes of medication, including what are called calcium channel blockers, just in case, because we're kind of desperate. The glaucoma is getting worse despite everything we're doing. But if they're on one of these medications, we might try stopping them. In this particular case, a calcium channel blocker for high blood pressure, and there are other types of medication. But I don't want people to overread into that. And I think that is something you need to have an individual discussion with your glaucoma specialist. Okay, so that's covering all three areas. And now I'm sure there'll be quite a few questions, and I look forward to taking them. So thank you for your attention.
Cheetah?
I don't know if Cheetah or Helen would like to lead the questions. Otherwise,
Cheetah, are you there? Okay.
I am here. Yes. Right. So I will definitely. I've got some of the questions. I'm going to start with the ones that were asked beforehand, and then one particular person, they wanted to know how many eye drops and treatments there were that do not contain sulfonamide, as they are allergic to it.
Really, it's only those carbonic anhydrase inhibitors that are sulfur drugs that you should avoid. And that's just one small class. So you should be able to take all the other drops. Unfortunately, the tablet, which sometimes we need to treat high pressure in an emergency, is the one that you have to be most careful of. So if you have an emergency and the pressure goes very high, it can be harder to bring your pressure down. But then nowadays, we often can do a little procedure at the slit lamp to let fluid out of the eye to lower the pressure, and we're getting more comfortable doing that. So yeah, should be okay.
Thank you. And this another person asked whether how much of the medication is absorbed systematically and how this can impact on general health. Is it a cumulative effect, over long term or short term? I know that you're saying that some of the time the side effects, as soon as you stop the medication, they stopped, but I'm guessing it's for other things it doesn't always.
Well, look, I think even if you do punctal occlusion, which the Glaucoma UK leaflet will tell you about, to try and stop the drop going down the nose and getting absorbed that way, it will be absorbed. You can't get away from it. You can reduce the amount of absorb, but your drops will go into your general system. Now, for most of the drops, most people won't notice any difference, but we're all different. And so if something strange is happening to you after starting an eye drop, do consider that it might be being caused by that. But the vast majority, as far as we know, the side effects we know that it causes are reversible and will go away very quickly on stopping the medication. So that's the good news. We are not aware of something having a cumulative long-term effect, but that doesn't mean it doesn't exist. It just might mean that we haven't picked up on it or detected it. So the good news is so many people using glaucoma medications, we haven't detected something that's cumulative. It's mainly the beta blockers that can cause these more short-term effects.
One of the questions that's coming from another platform is, can side effects be unilateral even if you're using drops in both eyes?
Generally, the answer is can, then it's yes, anything's possible. but it's unlikely. I think if you're getting a definite side effect on one side, then it's unlikely you get it on the other side. Now, sometimes taking an eye drop can make the eye pressure go too low, but that really only happens if you've had glaucoma surgery in the eye. And so if you've had glaucoma surgery in one eye and not in the other eye, then you're using the same drop in both eyes. It might only cause that effect on one side. But most of the time, the common sense approach would be, if you've only got it on one side and using the medication on both sides, really, you probably need to look for something else. I always keep an open mind, though.
Thank you. So we've got here, since I was diagnosed nearly 20 years ago, they've had numerous eye drops. Some of them have been difficult to obtain. They now need eye lubrication, and yet again, the most effective gel is it Theodolose Duo Gel has been very difficult to obtain over the 4 years. Is there any chance this situation will ever improve? And someone else has also liked that, so I'm guessing obviously that's not a good sign looking at your face.
Yeah, no, I know. It's really frustrating. And some of our main glaucoma medications, at least I would say with lubricants, there are so many different types. I would hope you could find something else that would tide you over. There are so many different lubricants. But for glaucoma medications, sometimes we don't have replacements. And because of supply chain issues, other issues, I like to blame Brexit on everything, but that's just my personal situation. I believe it's not just Brexit. It's all kinds of issues that mean supply chains get affected, and it is something we're vulnerable to. And I'm not sure we can promise that won't stop happening in the future.
Thank you. There's I'm just going to just answer this one about the recording being available later, and yes, hopefully it will be available on our YouTube channel. So I'm just going to do that with that one. They're coming in thick and fast, I'm afraid. So that one's that one. Let me see. I've lost my place now. If Brooklandia causes leaky blood vessels, wouldn't that be problematic for the patient with a macular edema resulting from retinal vein occlusion?
Not as far as it doesn't seem to affect those blood vessels in the back of the eye.
Thank you. And what else? Is Brooklandia more expensive than other drugs? I'm guessing that's obviously depending if it's not available.
Oh, it's from other branded drugs, it's quite similar. I think there's a lot of drugs are now off patent. They become much cheaper. But for ones that are still on patent, that are still branded, I think it comes out a bit cheaper. So that's something that I know because I've consulted with Santen, that the company that providing the drug in the UK, they've consciously tried to make this good value for the National Health Service, which is, I think, good news for us. But I think that will also help NICE's decision on whether it should be recommended or not.
It says, would over-the-counter antihistamine for hay fever cause an adverse response for glaucoma?
Most likely not. As we've said, there are, everyone's an individual, and so if you've been taking antihistamines and for some reason your glaucoma doesn't seem to be as well controlled, your doctor tells you, maybe you've got something very unusual, but typically no. Typically it won't affect it.
Thank you. Is Reclanda any good for normal tension glaucoma? Someone else has just asked.
Theoretically, at least, it might be better than some of the other medications because of that effect that it can bring the pressure down a good amount, even if your starting pressure is lower. So theoretically, it might be even better for normal tension.
Thank you. Just trying to find some. Sorry about this. I'm just trying to find ones that are going to have.
In the chat about rhinitis being flared up. I mean,
yes.
I've got quite a few patients that feel when you use eye drops, they can it does end up going down your nose. Even after you press for 5 minutes, it can go down and it can irritate it. I would say the vast majority of patients don't have a flare up of it, but if it does, then you need to speak to well, first, if you're not doing punctal occlusion, get the Glaucoma UK leaflet, look how to do it, and try doing that. If you are doing that and you're still getting the issue, then I think you need to speak to your glaucoma specialist, and probably your ear, nose, and throat specialist too.
Thank you. We've got one. Will the same drop remain effective for years, or does your eye just get used to it?
It's very hard to. Now, one particular type of medication, the alpha agonists, we know particularly have that effect. That's called tachyphylaxis, where over time the body just gets used to the drug and you lose the effect. For the other ones, less so. But what you will find is a lot of the time the effect seems to wear off. But that might not be the drug isn't working anymore, but just that underlying process that means your pressure's going up is getting worse. And so it looks like the drug's no longer working, but it probably is still working. But your plumbing is just getting worse and worse, and so you need more and more measures to counteract that.
So someone said, what do you recommend for dry eyes?
So there are different types of dry eyes. If you've and then different treatments depend on that. Like if the treatments are due to your eyelid oil glands not managing to get oil into your tears to make them more smooth over your eyes and not evaporate so quickly, then sometimes just cleaning the eyelids or using hot compressors or wiping the edges of the eyelids with special wipes can help. Something that helps pretty much everyone with dry eyes are lubricating drops, but there are so many different types, and I always recommend patients to try ones in different categories. There are ones which are Carmelos based, ones which are polyvinyl alcohol based, and ones which are hyaluronic based, and different people like different ones. If you are using glaucoma medications and you've got symptoms from dry eyes, I would see if you can move over to preservative-free eye drops. Some GPs don't like doing that because they're more expensive, but if you get a recommendation from your glaucoma specialist, that usually is possible.
Thank you. We're probably almost running out of time, but we've had a couple about sertraline or Lamatora gene for depression. Have they any interaction with Ganfort? And then there's a couple of questions about that.
Yeah, not that I've come across. Now, again, everything's individual. I don't know what interaction you're talking about. There are some people that say some of these medication classes might be associated with angle closure glaucoma. I don't think there's enough evidence for that. In terms of a specific interaction with Ganfort, I've not heard of that. So let's say a patient came to me with that specific query. While I've not come across it, maybe there's something reported somewhere. And what I would do is a literature review. And so I would look online. You could look on Google, but there are some more specialized search engines to see whether something like that has been reported. So if that is, for some reason, I don't know the background of this, something you're concerned about, then I would ask your GP or maybe your glaucoma specialist to search for that for you.
Thank you. I'm going to just leave the questions here, but I mean, one of them actually says,
there's one, sorry, there's one that I really want to take, because I don't want to cause more harm than good. Someone here is saying, I'm taking a calcium channel blocker, amlodipine, for my blood pressure. Should I tell my GP to change to another drug? No. For 99% of you, no, don't do that. If your blood pressure is controlled on this drug and you're tolerating, it's fine. There is some evidence to suggest that people who use calcium channel blockers are more likely to develop glaucoma than those who aren't. But how it affects whether glaucoma worsens or not, and whether that's really cause and effect or just by chance, we haven't proven. So for most people, no, please don't. There's no evidence to suggest you should do that. The only time I consider doing that is if you're one of the very unfortunate few where your glaucoma is getting worse despite everything we do. I've done glaucoma surgery, you're still getting worse. Then those are the times I start thinking about things like that. Some of these things where we don't have top level proof, but there's a suggestion some medications might have a harmful effect. I also talk about things like caffeine, alcohol, salt intake, lifestyle factors, which I understand are going to be in your next digital support group. Those things like that may or may not be discussed. That's the stuff I've done research on. But for the majority, if your glaucoma is controlled, you're not getting worse. I wouldn't start messing around with other things, because you might end up causing more harm than good. So I hope that's clear. I hope I haven't precipitated anybody going, to sort of, if your glaucoma is okay, I don't think you need to consider those kind of things.
Thank you very much, Anthony. I mean, someone else said, thank you for a very, very clear and comprehensive talk, which I actually heartily agree. I was actually I'm just going to launch the poll and then to see how much, we go back, there we go, where are we now? So I'm just going to launch the poll, but thank you very much for that, Anthony. I'm just going to share our helpline information with us as well. And then bear with me. I will go to the next. There we go. Right. So we thank you very much for this fantastic webinar, Anthony. I've actually learned loads this evening. I always do. For anybody that hasn't got a question answered, we'll try and do our best to answer them. Please give our helpline a call. They're open kind of like 9:30 till 5 on weekdays. And you can also email them on the helpline at Glaucoma UK. As Anthony said, we've got a couple of, we've always got one every month. They vary on what day of the month they are, but we've got one. The next one is not too far away on the 6th of August. And it's an introduction to glaucoma and lifestyle factors. That would be kind of quite interesting. And then in the 9th of September, we've got one on narrow angles and primary angle closure glaucoma. So I would say that I think we're pretty much on time. The questions are there. So I'm just going to end the poll. I'm going to stop sharing and just say thank you very much, Anthony. And I will see you all in a bit. Thank you very much.